If you've heard that the U.S. is scaling back vaccines to reduce the number that are needed to, quotes, better align with other countries, while at the same time hearing strong warnings about the dangers of this, it can sound a bit confusing. And because this affects both individual families and public health, I wanted to take some time today to slow this down and really break it apart. This is my Dr. Lady at the End of the Day podcast. It's a space where I take literally at the end of my workday and talk honestly about medicine, parenting, and the systems that we're all trying to navigate. I'm Dr. Cameo Carter. I'm a board-certified pediatrician and mom of 3. And today I wanted to talk about something I've been asked about a lot lately in patient visits. Recent statements suggesting changes in the U.S. vaccine schedule. Recently, the U.S. Department of Health and Human Services made statements suggesting that the U.S. should reduce the number of vaccines it was recommending in order to be more, and quote, aligned with the international consensus. Since then, parents have been asking me what I think about the changes to the recommended schedule. So I want to start with my answer very plainly. There aren't any changes. And I want to explain what I mean by that, because understanding how vaccine recommendations are normally made really matters here. For context, we're coming off a season with record pediatric deaths from influenza, and we are currently in the middle of another season with very high influenza activity. These aren't abstract discussions. These are real children, real hospitalizations, real families. So when suggestions are made, especially publicly, that sound like scaling back prevention without any scientific evidence, anything new, that isn't neutral. It's dangerous. Messaging matters. And while there are no changes in what doctors are recommending, having a major institution say something different is deeply concerning. Confusion spreads really quickly, hesitation increases, and the consequences are felt by children first. It's important to understand what these recent statements were not based on. They were not accompanied by new clinical trials. There was no new safety or efficacy data, no peer-reviewed studies, and no evidence showing harm from the current vaccine schedule. In medicine, recommendations change when data shows us a safer or more effective way to protect people. And we're especially careful about this when it comes to children. That did not happen here. There was no new science presented. And one phrase that stood out in this announcement was international consensus. And I want to pause there because that phrase sounds reassuring, but it doesn't mean what people think it means. There's no single international vaccine schedule. Countries design their immunization schedules based on disease prevalence in their region, their healthcare infrastructure, access to primary care and follow-up, and how reliably patients return for visits and how their public health systems are funded and delivered. It's also important to say this clearly. European vaccine schedules are actually very similar to ours. They protect against the same serious childhood diseases and are based on the same foundational science. Where differences exist, those differences are not about safety. They're about cost-benefit decisions made within very different healthcare systems. A good example of this is Denmark, which is often referenced in these conversations. Denmark has a fully centralized, universal healthcare system with near-perfect access to primary care, short distances to hospitals, and no financial barriers to hospitalization. When Denmark chooses not to routinely vaccinate all infants against rotavirus, for example, that decision is not based on safety concerns of the vaccine. It is based on a cost-benefit calculation within a system that can reliably hospitalize and treat dehydration when it occurs. As a result, Denmark has higher rotavirus hospitalization rates per capita than the United States. In contrast, in the US, where most infants are vaccinated against rotavirus, hospitalizations, IV fluid use, and severe dehydration from rotavirus have dropped dramatically. That difference reflects a systems-level trade-off, not a conclusion that the vaccine is unnecessary or unsafe. Denmark can make that choice because every child has guaranteed access to care, rapid hospitalization, and no financial barriers. That is not the reality in the United States. So copying Denmark's schedule without Denmark's healthcare system is not evidence-based medicine. The U.S. vaccine schedule is designed for the reality of healthcare in this country. That reality includes missed appointments, insurance changes, families moving, inconsistent access to care, and children who may not reliably re-enter the system if protection is delayed. Our schedule is built to protect children when we have the chance to see them. That's not excess. That's prevention informed by reality. The recommendations we follow are supported by decades of research and by clinicians whose authority comes from science, not politics. And that includes the American Academy of Pediatrics, the American Academy of Family Physicians, the American College of Obstetricians and Gynecologists, the Infectious Diseases Society of America, and vaccine safety research networks like the Vaccine Safety Data Link, along with virtually every other major medical and scientific organization. These recommendations are continuously reviewed, and they change only when evidence shows us something better. Right now, that evidence does not support doing anything differently than what we're currently doing. So when parents ask me, what are your thoughts on the changes to the vaccine schedule? My answer is simple. There aren't any. The recommendations we follow are the same ones we've been following because the science hasn't changed. And until we have clear, peer-reviewed evidence showing a safer or more effective approach, those are the recommendations I will continue to follow. Not because I'm rigid, not because I'm dismissive, but because my responsibility is to protect children with the best available evidence. Parents asking questions are not the problem. Curiosity about things we don't have answers to is not the problem. Wanting to understand is not the problem. I welcome those conversations, but I will not equate rhetoric with research, and I will not soften scientific truth when children's lives depend on it. Medicine evolves, science evolves, and when the data changes, I will change with it. But until we are shown clearly, transparently, and scientifically that there is a better way to protect children, the recommendations stand.